Welcome back to the deep dive. We are really looking forward to unpacking this stack of sources today because we are dealing with a topic that sits right at this weird intersection of, biology, physics, and a very specific kind of human anxiety. We're talking about glaucoma.
It is a heavy hitter.
Yeah.
And frankly, looking at the literature, it is one of the most misunderstood conditions in all of medicine.
Really?
Oh, yeah. Most people, they just treat it as a synonym for high eye pressure. But the reality is it's significantly more complex.
Yeah.
And in a way, more tragic.
That's the first thing that really jumped out at me from the reading. I, like a lot of people, I think, always assumed glaucoma was just a plumbing issue.
Right.
The pressure goes up, the eye hurts, you fix it. But the text, it frames it as a plumbing problem that actually results in a neurological disaster.
Yes.
It's not an eye disease in the way, say, a cataract is. It's a brain disease that happens to be in the eye.
That is the critical distinction. If you take nothing else away from this deep dive, understand this. Glaucoma is defined as an optic neuropathy.
Neuropathy.
Nerve damage.
Nerve damage. Specifically, we are talking about the optic nerve head, or what we call the optic disc. This is it's the physical cable that connects the camera of your eye to the processing center of your brain.
Okay.
Glaucoma is the process of that cable slowly fraying until the signal is just lost.
And the mission then for this deep dive, based on the materials, is to really demystify how that fraying happens.
Exactly.
Because it is often called the silent thief of sight, which it sounds a bit like a Victorian melodrama villain, but it seems scientifically spot on.
It's entirely accurate. The tragedy of glaucoma is that the damage is often irreversible. Once those nerve fibers are gone, they are gone.
You can't get them back.
We can't grow a new optic nerve. So the entire game, all the chemistry, all the lasers, all the surgery, it's all about preservation. It's about saving what is left.
Okay, so let's get to the hook that really surprised me. We mentioned high pressure a second ago. Historically, and I think in the public imagination still, intraocular pressure, IOP, it's the villain. It's the bad guy, right?
But the source material says that pressure is, well, it's complicated.
It's the central paradox of the disease. Intraocular pressure is the single most significant risk factor. It is the main lever we can pull to treat the disease.
Okay.
But it is not the disease itself. You can have sky-high pressure and a perfectly healthy nerve. We see it all the time.
Wow.
And conversely, you can have what we consider normal pressure, textbook normal, and still be going blind from glaucoma.
Which is, that's terrifying. It means you can't just rely on a number to tell you if you're safe or not.
Exactly. Pressure is a clue, a very important clue, but it's not a verdict.
Right.
And to understand why pressure matters at all, we have to understand the landscape of the disease. The sources, they divide this into two main camps. And they are so different, they almost feel like completely different diseases.
Right, so we have primary open-angle glaucoma, POAG, and then closed-angle glaucoma, or CAG.
Correct. Let's start with primary open-angle glaucoma, POAG.
Okay.
This is by far the most common form. In the literature, when you see ocular hypertension linked to a chronic condition, this is usually the neighborhood we're in. The key feature here is that it is slow. It's chronic. It's insidious.
So this is the thief.
This is the thief.
Yeah.
The patient usually has no idea it's happening. There is no pain. Their vision seems fine. But slowly, over years, sometimes decades, the nerve is dying.
And then we have closed-angle glaucoma.
Which is the total opposite.
Yeah.
It's often acute. It's traumatic. It is a physical blockage that happens suddenly.
So not a slow leak.
No. If open angle is a slow leak in the basement that rots the foundation over a decade,
right.
Closed angle is a pipe bursting in the kitchen while you're eating dinner. It's a crisis.
And both of these can be inherited. Is there a genetic component?
Oh, yes. Genetics play a massive role. They can be congenital, so present at birth, or they can be secondary to trauma or other diseases or even drugs.
We'll get to the drugs. That list is something else.
It is. But for the vast majority of people, this is a condition that emerges from the mechanics of their own anatomy.
So let's talk about those mechanics. I love the analogy the source uses to explain it. The sink. It seems to be the only way to really visualize what's going on with intraocular pressure.
It's the perfect analogy. Your eye is a pressurized sphere. It needs to stay inflated to hold its shape so the lens can focus light properly.
Oh, right.
To do that, it's filled with a fluid called aqueous humor.
And to be clear, this is not tears.
No, absolutely not tears. Tears are on the outside. Aqueous humor is on the inside, circulating in the front part of the eye. So think of the eye as a kitchen sink.
Okay.
You have a faucet and you have a drain.
The faucet, in this case, is the ciliary body.
Correct. The ciliary body is a ring of tissue that sits right behind the iris. and it's constantly pumping this aqueous humor into the eye. That's your inflow.
And what's the fluid for?
It provides nutrition. It feeds the lens and the cornea, which don't have their own blood vessels. So the fluid flows from behind the iris, through the pupil, and into the front chamber of the eye.
And since the eye is a closed system, that fluid has to go somewhere. It needs a drain.
It needs a drain, and that's the outflow. The drain is a fascinating structure called the trabecular meshwork. It sits right in the angle where the cornea, the clear part, meets the iris, the colored part.
The meshwork, so it's like a filter.
It's exactly like a filter or a sponge. The fluid filters through this meshwork and then exits back into the bloodstream.
So IOP, the pressure in the eye, is just the balance between the faucet and the drain. It's simple physics.
It's Physics 101. If the faucet is running too fast or if the drain gets clogged, the water level in the sink rises.
Right.
But in the eye, the water can't spill over the edge, so the pressure just rises instead.
And here is a detail from the source that I found totally fascinating. This pressure isn't static. It's not like your shoe size. It's not a fixed number.
No, not at all.
It changes throughout the day. They call it diurnal variation.
This is a huge factor in diagnosis and one that's often missed.
Yeah.
Your eye pressure follows a rhythm, a circadian rhythm. It typically hits a minimum around 6 p.m.
In the evening.
Right. And a maximum right when you wake up in the morning.
So hang on. If I have an eye appointment at 5:30 p.m., I might get a totally normal reading, even if my pressure was dangerously high at 7:40 a.m. that same day.
Exactly. That is the danger of a single snapshot in time. It's why some people need 24-hour pressure monitoring.
Wow.
And it's not just the time of day. The source notes that IOP changes with your pulse, with your blood pressure, even with your posture.
How so?
If you lie down, your eye pressure goes up. If you, do a headstand, it skyrockets.
So yoga instructors need to be careful.
Or if you play the trumpet and hold your breath, it spikes. It's incredibly dynamic.
That really makes the air puff test at the mall seem a little less definitive.
It's a screening tool. It's a good one. But it's not a complete picture. You have to understand the dynamic nature of the plumbing to really get it.
Okay, so let's apply this plumbing to the two types of glaucoma. Start with the open angle. The open part refers to the drain, right? The angle.
It refers to the access to the drain. That's the key. If a doctor looks into the eye of a patient with POA using a special lens, the angle where the iris meets the cornea looks wide open. You can see the drain.
So there's no physical barrier?
None. The doorway to the drain is clear.
So why is the pressure going up? If the drain is open, what's the problem?
That is the million-dollar question in ophthalmology. We believe it's a microscopic resistance within the trabecular meshwork itself.
Ah, so the drain looks clear, but it's not working right.
Exactly. The pipes deep down are rusty or gunked up. The fluid meets resistance as it tries to leave. It's a problem of function, not structure.
So the faucet keeps pouring, the drain is sluggish, and the pressure just creeps up over time.
Slowly. And that pressure, that relentless pressure, pushes against the weakest part of the eye wall. And that's the optic nerve head.
Okay.
It sort of cups it out like pushing your thumb into a soft melon. It physically damages the nerve fibers.
But the source was very specific, that pressure isn't the only thing killing the nerve in POA. It lists some other mechanisms that sound pretty intense. Ischemia.
Right, so we have to ask the next question. Why does pressure kill the nerve? One leading theory is ischemia, lack of blood flow.
Okay.
The pressure might be compressing the tiny, tiny blood vessels that feed the nerve, effectively strangling it of oxygen and nutrients.
And excitotoxicity, what is that?
That's a biochemical cascade. When nerve cells get stressed or injured, they release chemicals, specifically an amino acid called glutamate, that overstimulate their neighbors.
And that's bad.
It's very bad. It causes a chain reaction of cell death, like one panicked person in a crowd causing a stampede. The source even mentions autoimmune reactions being involved.
So in POA, you have this complex, toxic soup of pressure, vascular failure, and biochemistry.
Yes, it's a multifactorial attack on the nerve.
Okay, now contrast that whole process with the mechanics of closed-angle glaucoma.
Totally different world. This is a pure structural failure, an architectural problem.
Not a biochemistry problem.
Not primarily. In this case, the iris, the colored part of the eye, physically moves forward. It bunches up and pushes against the cornea, covering the trabecular meshwork completely.
So it's literally putting a stopper in the sink drain.
Yes, a perfect physical blockage.
Yeah.
And because the faucet is still running, the pressure doesn't creep up, it spikes.
Fast.
Rapidly. It can go from normal to crisis levels in a matter of hours.
Which leads us directly to the clinical experience, right? Because the biology completely dictates the symptoms.
Absolutely. Let's look at POAG, the silent thief. Because the pressure rise is so slow, the eye stretches and adapts slightly over time. There's no pain. The patient feels absolutely nothing.
And the vision losses, it's sneaky.
It traps you. It's designed to fool you. Glaucoma affects peripheral vision first, your side vision.
Okay.
But human beings are very central vision creatures, and our brains are designed to fill in gaps. If you lose a patch of vision in your periphery, your brain just paints over it with what it thinks should be there.
So you don't see a black spot. You don't see a hole.
No. You just see less. You might start bumping into door frames on one side, or maybe you don't notice a car coming from the side when you're trying to pull out into traffic.
But if you look straight ahead, everything seems fine.
Your central vision, your ability to read a book, to recognize a face, is preserved until the very, very end stages of the disease.
That is the trap. You think, I can read the newspaper, my eyes are fine, while the walls are literally closing in on your vision.
Precisely. Now, closed-angle glaucoma is the complete opposite. It screams at you.
The source lists prodromal symptoms. These are like the warning shots, the early alarms.
Yes. Before the drain closes completely, it might close intermittently, then open back up.
So you get temporary spikes.
Right. And during those spikes, you might notice blurred vision, or classically, you'll see halos around lights.
Like rainbows around a street lamp at night.
Exactly like that. That happens because the high pressure forces fluid into the cornea. The cornea swells up like a waterlogged sponge, and that swelling scatters the light, creating the halo effect.
And when the drain closes fully, the acute attack.
That is a full-blown medical emergency. The pressure is so high, the cornea becomes cloudy and edematous, which just means swollen. The pain is severe. It's described as a deep, boring ocular pain.
Not just on the surface.
No, deep inside. And because of the nerve connections in the head, it often causes systemic symptoms.
Like what?
Nausea, vomiting, abdominal pain, and diaphoresis, which is just heavy, profuse sweating.
I can see how that leads to misdiagnosis. If you show up at the ER vomiting with a severe headache, they might think you have the flu or a migraine, not an eye problem.
It happens all the time. But a rock-hard, red, painful eye is the giveaway.
Let's pivot back to this diagnostic gray area we touched on earlier. The source had a section basically called Pressure is Not Destiny. This is where the real nuance kicks in.
This is where we have to separate the measurement from the pathology. It's critical. And we have two subtypes that just break all the rules. First, ocular hypertension.
Which defines a specific pressure number, right?
Yes. In the literature, the statistical cutoff is usually around 21 millimeters of mercury, or mmHg.
Okay.
If you are consistently above 21, you have ocular hypertension. But, and this is the key, you have a perfectly healthy optic nerve. No cupping, no visual field loss, nothing.
So I have high pressure, but my optic nerve is tough enough to take it. It's not being damaged.
Correct. You are at high risk, a very high risk for developing glaucoma.
But you don't have the disease yet. We might treat you to be safe, or we might just watch you like a hawk.
And the inverse of that is normal tension glaucoma.
This is the scary one. This is the one that keeps ophthalmologists up at night.
Why?
Because you have an IOP of, say, 15. It's less than 21 millimeter Hg. Your pressure is, by all accounts, normal, but your optic nerve is cupping, and you are actively losing vision. You have progressive, damaging glaucoma.
So in this case, my nerve is just, it's made of tissue paper. It can't handle even normal pressure. Essentially, yes, it's incredibly fragile. It might be a blood flow issue. It might be a structural weakness. We don't fully know. But for these patients, normal pressure is still far too high.
So you have to treat them.
Oh, yeah. We have to drive their pressure down to single digits sometimes, get them to 10 or 9 to save their sight.
So how does a doctor actually confirm the diagnosis then, if the pressure number is so unreliable?
You have to look at the damage. For POAG, you confirm it by looking at the optic disc changes, the cupping with a microscope, and you have to map the visual field with a special machine to find those invisible blind spots.
It's about the nerve, not the number.
It's always about the nerve. And for closed angle, you use a technique called gonioscopy.
Which is what exactly?
You put a special mirrored lens right on the surface of the eye. It's a contact lens.
Okay.
It allows you to look around the corner and see directly into the angle. You can actually visualize if the iris is blocking the drain. It's definitive.
Before we get to the drugs that fix all this, we need to talk about the drugs that cause it. Secondary glaucoma. The source provided a list of medications that can induce glaucoma, and frankly, it includes stuff half the population is taking.
It's a vital list. This is something every patient and every doctor needs to be aware of, because drug-induced glaucoma is entirely preventable, but only if you know the risks.
The biggest offender on the list seems to be corticosteroids. Steroids.
Steroids are dangerous for the eye. They just are. Ophthalmic corticosteroids, steroid eye drops, are the highest risk.
How do they do it?
They cause a physical change in the trabecular meshwork that increases resistance to outflow. They literally gum up the drain over time.
But it's not just eye drops. The source lists systemic steroids pills and even nasal sprays and inhalers.
Yes. If you were using a high-dose steroid nasal spray for allergies every single day for years, you are absorbing some of that systemically.
And that gets to the eye.
For most people, it's fine. But for a subset of the population we call steroid responders, people who are genetically predisposed, it can push their pressure into the danger zone.
That is wild. I don't think most people check the side effects of their allergy spray for potential blindness.
They don't. And look at the table in the source, table 65-1. It distinguishes between triggers for open angle versus closed angle.
Right. So steroids are an open angle problem. They gum up the drain. What triggers the closed angle type? The blockage.
Drugs that dilate the pupil.
Why?
When the pupil dilates, the iris tissue bunches up in the periphery. If you have a naturally narrow angle to begin with, that bunching can be enough to block the drain.
So you're creating the traffic jam.
You're creating the traffic jam. So we are looking at any drug with anticholinergic properties.
Which includes a lot of things.
A lot. Over-the-counter antihistamines, older heterocyclic antidepressants, even some common SSRIs like paroxetine or fluoxetine, motion sickness patches.
So someone with undiagnosed narrow angles could take an antidepressant, their pupils dilate just a little bit, and boom, they're in the middle of an acute angle closure attack.
It can happen. And it does. That's why the warning in the text is so clear. The potential to worsen glaucoma depends heavily on the type of glaucoma the patient has. Your psychiatrist needs to know about your eyes, and your eye doctor needs to know about your medications.
Okay, let's move to the solution. The war on pressure. We have a diagnosis. How do we fight back?
The goal, first and foremost, is preservation. We want to lower the IOP by about 20% to 30% from the baseline, initially. That's the standard target.
So if I start at a pressure of 24, we want to get me down to, what, 17 or 18?
Roughly, yes. But the target is personalized. It's not one size fits all. If you have very early, mild visual field loss, maybe getting you under 21 is fine.
But if it's worse?
But if you have advanced disease or if you have that normal tension glaucoma we talked about, we need to go strictly low. We might aim for a target pressure of less than 10 millimeter Hg.
And when do we decide to treat ocular hypertension, the high-pressure, healthy nerve people?
That's a risk calculation, a judgment call. The source suggests treating if the IOP is consistently over 25 millimeters Hg, or if the vertical cup-to-disc ratio is greater than 0.5.
Which means the nerve is starting to look a little suspicious, even if the visual field is still okay.
Exactly. It's starting to cup. Another huge factor now is central corneal thickness. We measure it on everyone.
Why does the thickness of the cornea matter?
2 reasons. 1, a thin cornea less than 555 micrometers might indicate a structurally weaker eye overall, and that's a major independent risk factor.
Okay.
And 2, it affects our pressure measurement. A thin cornea gives artificially low pressure readings. So your pressure is actually higher than our machine is telling us it is.
So you're underestimating the danger.
Correct.
Okay, let's open the pharmacological arsenal. I love how the source groups these by their plumbing mechanism. We have drugs that turn down the faucet and drugs that open the drain.
It's the best way to understand them. Let's start with the faucet turners, the inflow reducers.
The classic here is the beta blocker. Timolol seems to be the big one.
It was the gold standard for decades. Beta blockers work by blocking beta adrenergic receptors on the ciliary body. This essentially tells the cells to stop producing so much fluid.
Turn down the tap.
Turn down the tap. But beta blockers are heart drugs, systemically.
Right.
And that's the catch. Eye drops don't just stay in the eye. They are absorbed into the bloodstream through the nose and throat. So timolol can lower your heart rate, drop your blood pressure, or cause bronchospasm in people with asthma.
So you're fixing the eye but potentially hurting the heart or lungs. That's a serious trade-off.
It is. The source notes that a drug called Betaxol is beta-1 selective, meaning it tries to target the eye receptors more than the lung receptors, but the risk is always there.
What else turns down the faucet?
Carbonic anhydrase inhibitors, or CAIs. The drops are dorzolamide and brinzolamide.
And how do they work?
Carbonic anhydrase is an enzyme that's required to produce aqueous humor. So you block the enzyme, you block the fluid production. Simple as that.
And alpha-2 adrenergic agonists, like brimonidine.
Brimonidine is a cool drug because it has a dual action. It reduces inflow, so it turns down the faucet.
Okay.
And it also increases something called uveous scleral outflow.
So it works on both ends of the sink.
It does. But its Achilles heel is a very high rate of allergic reactions. A lot of people get red, itchy, uncomfortable eyes from it.
Okay, now let's talk about the modern superstars, the open-the-drain drugs, and specifically prostaglandin analogs.
Latanoprost, Biomotoprost, Travoprost. These are the first-line therapy for most patients today. They've really revolutionized glaucoma care.
Why are they the favorites now?
Efficacy and convenience. First, you only take them once a day, usually at night. That's huge for adherence. And second, they are incredible at lowering pressure, often better than beta blockers.
And their mechanism is opening the drain.
Yes, but not the main drain. They work by increasing uveoscleral outflow.
Which is like the backdoor drain, right? Not the trabecular meshwork.
Exactly. They don't just unclog the main drain. They relax the muscle tissues within the eye wall, which allows fluid to seep out through an alternate pathway.
They open up a whole new exit route.
A whole new exit route. It's very clever.
But they have some bizarre side effects. The source mentions they can change your eye color.
They can. They can increase the brown pigment in the iris. So if you have blue or green or hazel eyes, they can slowly turn brown over time, and it's permanent.
Wow.
And, maybe more famously, they cause hypertrichosis.
Which is?
Growth of the eyelashes. They make your lashes longer, thicker, and darker.
Wait a minute. Isn't that what Latisse is? The eyelash growth serum?
It is exactly what Latisse is. Latisse is just Bimatoprost, the glaucoma drug, in a different bottle with a different label marketed for cosmetics. They discovered it as a side effect of glaucoma treatment.
That is fascinating. Okay, last category here. We have cholinergics, like pilocarpine. This is the old school drain opener.
Very old school. It works by contracting the ciliary muscle. And when that muscle contracts, it physically pulls on the trabecular meshwork, stretching the little holes open.
It's like using a winch to pull open the drain cover.
That's a great way to put it.
But the source says it's third line now. Not used much.
Because the side effects are rough. It constricts the pupil down to a pinhole, which makes things look dim and can cause problems driving at night. It also causes brow aches and headaches because that muscle is constantly in a state of cramp. We just have better, gentler options now.
So how does a doctor navigate this whole menu? What's the treatment algorithm look like?
You start simple. A single agent, usually a prostaglandin analog or, in some cases, a beta blocker. And here is a key procedural point from the source. You should do a monocular trial.
A monocular trial. You treat only one eye.
Yes. If both eyes have high pressure, you treat just one eye and you leave the other one alone for a few weeks.
Why?
This lets you see if the drug is actually working for that specific patient or if their pressure is just fluctuating naturally. It's your built-in control.
It's a controlled experiment on your own face.
It's the only way to be scientifically sure that the drop is the reason the pressure went down.
So what happens if the drug doesn't work or if the side effects are bad?
Then you switch classes. If the prostaglandin made your eyes red, you try a beta blocker. If that doesn't work, you try a CAI. Or you can teach the patient nasolacrimal occlusion.
This is the technique to stop the systemic absorption we talked about.
Yes. You instruct the patient to gently pinch the tear duct, the inner corner of the eye, for a minute or two right after putting the drop in.
And what does that do?
It keeps the medicine in the eye where you want it and prevents it from draining into the nose and throat and getting into the bloodstream. It makes the drug more effective in the eye and protects the heart and lungs.
And what if one drug just isn't enough to hit the target pressure?
Then you add a second agent from a different class. Combination therapy is very common, but you always have to watch out for something called tachyphylaxis.
Which means the drug just stops working over time.
Yes. The body adapts, the receptors get saturated, or they downregulate. This is especially common with beta blockers. You might have great pressure control for 2 years, and then all of a sudden it starts to creep back up. That's why monitoring glaucoma never stops. It's for life.
Okay, that covers the chronic management. But we need to address the crisis. The acute closed-angle attack. This is the ER scenario.
This is all hands on deck. The pressure might be 60, 70, 80. The eye is at risk of permanent damage within hours. We need to drop the pressure, and we need to do it rapidly to save the eye.
What is the definitive fix for this?
The definitive fix is a laser procedure. It's called a laser peripheral iridotomy, or LPI.
That's a mouthful.
It is, but the concept is beautifully elegant. You use a laser to punch a microscopic hole in the outer edge of the iris.
A bypass valve.
It's a perfect bypass valve. The fluid that's trapped behind the iris now has a new path to flow directly to the front chamber. It equalizes the pressure, and the iris physically falls back away from the drain. the plumbing is restored.
But you can't always do a laser on a cloudy, inflamed eye immediately, can you?
No, you can't. The cornea is too swollen to see through, so we need a drug bridge to get the patient to the laser.
So what's in the drug bridge?
First, we have to clear the cornea. We use osmotic agents. Orally, we can give them a thick liquid called glycerin, or, more commonly in the ER, we give mannitol through an IV.
And how do those work? They sound serious.
They turn the blood into a hypertonic sponge. They create an osmotic gradient that sucks water out of the vitreous jelly of the eye and pulls it back into the bloodstream. It literally dehydrates the eye from the inside out.
That sounds intense.
It is very effective and very fast. At the same time, we hit them with our secretory inhibitors, our faucet turners, a beta blocker drop, an alpha-agonist drop, stop the inflow.
Okay.
And we also use pedocarbine.
Ah, the old school drug comes back for a cameo.
It has a very specific and crucial role here. By constricting the pupil, it physically pulls the iris tissue taut and away from the meshwork. It helps unblock the drain mechanically while we wait for the pressure to drop.
And corticosteroids are used here too.
Yes, to put out the fire. The eye is incredibly inflamed and angry.
Yeah.
Steroid drops reduce the swelling and prevent synechia. That's when the inflamed iris gets sticky and actually adheres to the lens or the cornea. You don't want permanent adhesions to form.
So it's a massive chemical assault to prep the eye for the definitive laser fix.
It is. And once the laser is done, the cure is usually permanent for that specific attack.
We have covered an immense amount of ground here, from the physics of the sink to the biochemistry of nerve death to the chemistry of the drugs. Let's try to distill this into some key takeaways for the listener.
I think there are 4 main pillars here that are really important to remember.
Okay.
1, glaucoma is an optic neuropathy, not just a pressure number. Remember, normal tension glaucoma. You can have the disease with normal pressure. It's about the nerve.
Got it.
2, know your type. POAG is silent and slow. CAG is acute and painful. They're completely different beasts with different risks and treatments.
Right.
3, treatment has evolved. We have moved from simple beta blockers to sophisticated prostaglandin analogs that utilize that uveoscleral backdoor pathway. There are more and better options than ever.
And
4, screening is non-negotiable. You cannot feel your optic nerve dying until it is far, far too late.
that is a very solid summary, and I want to end on a thought that kept nagging me while reading all of this. We have all these incredible drugs, prostaglandins, alpha-agonists, osmotic agents. We have lasers that can punch tiny holes in the eye. But the source material hints at a major point of failure that has nothing to do with science. The patient.
Adherence. It is the Achilles heel of all glaucoma treatment.
It makes a certain kind of psychological sense, doesn't it? You have a disease with 0 symptoms, for POE at least. You feel totally fine, but the doctor gives you eye drops that might sting, might make your eyes red. They cost money.
And you have to remember to take them every single day. For the rest of your life, it is very, very hard for humans to prioritize a preventative treatment for a silent threat that feels abstract.
But the reality is...
The correlation between pressure and damage is complex, but the correlation between no treatment and eventual blindness is very, very strong.
So the final takeaway is, if you are prescribed the drops, take the drops. Even if you feel fine.
Especially if you feel fine. That means it's working. The best drug in the world doesn't work if it stays in the bottle.
Well, on that note, I think we have successfully navigated the very complex plumbing of the human eye. Thank you for helping us unpack this. It's a lot more than just an air puff test at the optometrist.
It's a fascinating, complex system. My pleasure. Happy to do it.
And thank you for listening. Take care of your eyes, and we'll see you on the next deep dive.